You are the Canadian Donation and Transplantation Research Program. You are CDTRP.
The CDTRP is a network of more than 400 clinicians, senior, mid, and early career researchers, trainees, patient, family, and donor partners, and 100 partner organizations. Our network has supported 275 collaborative research projects and has mobilized research into policy change, legislation, commercial products, and improved knowledge for patients, families, and donors. Every year, CDTRP supports between $30 to $40 million in grant applications, something around 60 to 70 individual applications. You are CDTRP. These achievements wouldn't be possible without your hard work.
CDTRP Research Services is a platform that supports principal investigators to develop high-quality research in donation and transplantation. We work hand-in-hand with CDTRP investigators to maximize the effectiveness of research teams through support with funding development, project management, patient, family, and donor partnership, knowledge mobilization, events, and trainee support. Across the 5 research themes, we help teams mobilize new knowledge to ensure patient, family, donors, healthcare systems, partners, and stakeholders equitably benefit from research results.
If you are a basic scientist and would like support with your knowledge mobilization plan, if you are a busy clinician scientist with limited time for research but would like to run a multi-site study, if you are an early career researcher and looking for collaborators to help with your grant applications, if you value patient, family, and donor engagement but are not sure how to find the right patient partners or what role they will have in your project, if you don't have full-time research staff but need support,
we are here to help. Our experienced management team can support you at every stage of your research in donation and transplantation.
Now you are probably thinking, how can I request CDTRP Research Services support? The answer is simple. Go to the CDTRP Research Services Platform website, fill out the form to request support, and we will get in touch with you to discuss your needs. That's it.
We.
Nous.
Noi.
Nos.
Emis.
Nosotros.
Menk.
Kiano. We. Kiano.
Our CDTRP, and we will drive research advances so that every wish to donate is fulfilled and transplantation becomes a lasting and sustainable cure.
You are CDTRP.
Email us today.
Move on to our last session of the morning called Bridging Research and Patient Engagement Insights from the CDTRP Supported Projects. And joining us today, we have Dr. Dimitri Rosenberg, who is pulmonologist at the University Health Network and affiliated with the Ajmera Multi-Organ Transplant Program in Toronto, Canada. He is an assistant professor at the Temerity Faculty of Medicine and University of Toronto. Dr. Rosenberg's research aims to understand the impact of physical fitness and skeletal muscle function on daily physical function, quality of life, frailty, healthcare use, and survival before and after lung transplantation. Dr. Rosenberg is applying imaging techniques, non-invasive measures, and histopathological muscle evaluation to gain a greater understanding of the functional impairments experienced by patients with advanced lung disease and the response to rehabilitation. Dr. Rosenberg is looking to translate his clinical experience and passion for exercise training to improve health outcomes in individuals with lung disease and across solid organ transplantation. And Sandra Holsworth, her healthcare journey and dedication to co-design was truly launched when she received her liver transplant in 1997. After several years of going undiagnosed with a rare liver disease and Crohn's disease, she also required a permanent ileostomy in 2012. Sandra had stage 4 chronic kidney disease due to long-term immunosuppression medications, and Sandra is now on hemodialysis due to an acute kidney injury caused by sepsis in March of 2024. For the last decade, Sandra has been actively engaged in the Canadian Donation and Transplantation Research Program as patient partner co-lead on the quality of life theme. Sandra has been a patient partner on several research projects, has completed peer reviews, co-authored position papers, and has been a co-applicant on published research projects. Jia Lin is a clinical research project coordinator working alongside Dr. SamanthaAnthony, a health clinician scientist in the Child Health Evaluative Sciences program at the Hospital for Sick Children. The Anthony Lab examines the biopsychosocial impact of pediatric chronic illness and patients with families, with a focus on patient engagement, patient-reported outcome measures, implementation sciences, and mixed methods. In her role, Jia leads multiple clinical research studies across the research pipeline, including a current multi-phase cross-Canada study exploring the experiences of Indigenous children and families who have received solid organ transplantation. Rooted in patient and community engagement, this research employs storytelling to consider the multiplicity of knowledge, including Indigenous knowledge, to advance child health equity. Jia is experienced in equity-oriented, patient-engaged health research and applying critical qualitative approaches to illuminate patients' voices. She will begin her PhD this fall of 2024. And last but not least, Carmen Carriere lives on the ancestral and the treaty territory of the Tsawwassen First Nation and the unceded territory of the Musqueam people outside of what is colonially known as Vancouver, British Columbia, where she and her husband raised her 4 children. Carmen is a proud Michif woman and a citizen of the Métis Nation British Columbia, whose roots run deep in the Red River from St. Boniface to St. Laurent, Manitoba. Carmen received her Bachelor of Arts in History and her Bachelor of Education from the University of British Columbia, while she recently completed the IndigenousWomen in Community Leadership program with the Coady Institute at St. Francis Xavier University. Informed by her lived experience advocating for her father and daughter who live with a disability and chronic health conditions, Carmen is passionate about culturally sensitive and accessible healthcare. Walking alongside her family has given her valuable experience and insight into systems that are often difficult to navigate, underscoring the need to be grounded in culture and community. She has brought this experience to her work as a secondary teacher, coordinator for the Children's Heart Network, and her roles with the Children's Organ Transplant Society and CDTRP. So thank you all for joining us today and for sharing with your experiences. So today is going to be an open conversation. So I will ask the panel some questions. I encourage everybody to jump in. Feel free to post your questions. For our audience, if you have any questions, please make the comments as we go. You can either post your questions in the chat, you can send them anonymously to CDTRP Q&A, or you can raise your virtual live hand and I will catch you. So let's just get started. It's an exciting opportunity to chat here today. So I think I'm going to ask the first question to Dr. Rosenberg, if I may. Can you describe your overall experience working with patient partners in your research and focus on how PFD partners have influenced the direction or outcomes of your projects.
Sure. Thanks, Leonard and CDRP for having me today and the kind introduction. I'll probably speak on 2 or 3 projects and focus in within the CDRP light. And as an early career investigator, I've just transitioned to mid-career, but kind of began these projects 3 to 4 years ago in the midst of COVID. And the project where I got to know Sandra closer, obviously, I knew Sandra from before with Sunita Matar and some of the work that she was doing with Tanya, but is a home-based exercise program combined with liver and lung transplantation. And CDRP, the patient, donor, and family partners had facilitated that introductory meeting. And folks, we've done a couple of meetings as well in other projects. For instance, a telerehabilitation meeting that was facilitated with CDRP, and now we've engaged on a project with through CIHR, inspiratory muscle training. More importantly, these 3 experiences have really provided a couple, and they're different phases, these projects. Number one, the experiences have been very rewarding, but more importantly, I've realized it's not about completing the project, but it's where you need the patient partners more. It's throughout the entire project, but it's the translational side of things, at least in my research, thinking about the next steps and hearing from the patient partners what is more important, what are the lessons learned, and the investigation. So with some of the projects wrapping up, for instance, the telerehabilitation project where we had a 2-day virtual forum, we're thinking about what are the next steps, and that's kind of hearing from the patient partners, but also the investigators, quite critical. Involving the patient partners early and family throughout the process of planning has been critical as well. So at all stages, through the grant writing process, through the handouts that would be provided to the patients and ensuring that the appropriate health literacy is there, but also the reading level. And then also engaging the patient partners, finding out if things aren't going smoothly, if they have any suggestions on recruitment of participants or any tweaks that can be made to the project. So it's been a rewarding experience, but as a new early career investigator, I've learned quite a bit as well. It's not something that we get trained on throughout at least my graduate training or throughout med school, as you've heard, or residency. And certainly, I can speak to some of the EDI principles that will come up as well. But I'll probably stop there. And if there's some specific questions, Sandra's been very kind, involved in a number of projects, so she could certainly provide some thoughts and pass it on to the other panel members as well. Thank you.
Thanks, Dimitri. Yeah, it sounds like CDTRP is, as they've evolved and grown, they're offering some great support that way. So yeah, it's great. Maybe I can ask the same question of Jia. Would you care to comment as well?
Yeah, absolutely. And I want to say thank you to CDTRP and everyone here for the opportunity to share this space. I work with Dr. SamanthaAnthony, who's a health clinician scientist at Sick Kids, and I'm joined here with Carmen as our patient partner. One of our projects is a co-developed multi-phase, multi-site program of research aimed at exploring the experiences of pediatric transplant for Indigenous patients and families across the transplant experience, the journey. And I think recognizing, the history of unethical research on Indigenous populations rather than with Indigenous populations, as well as, the Western colonial structure of research, we knew that, engaging patients from the beginning was, a really, really key and critical stage, and that authentic patient engagement was necessary. So, we took a few different approaches in trying to make sure that this research is being done in a good way. We collaborated with the late Mary Bocage, who was a kidney transplant recipient and a huge advocate for patient-engaged Indigenous health research, and really involved her from the beginning as a co-PI on this project. And, with the idea formation stage, the grant writing stage, what methodology and protocols to use, and really, recognizing patients and families' kind of lived experience in research. We also began building, partnerships with First Nations and Métis patients and parent partners from our different sites as partners in this research. So forming an advisory committee and inviting them to share their lived experience to guide this research, providing feedback, really, making decisions to shape the direction of this research, and really recognizing that their expertise is research evidence, and that patients and families can be, researchers involved on the study team. I think this, the impact of involving patients have been multifold. So really influencing the research direction, the research questions, the protocol. So especially with, engaging with First Nations, Métis, and Inuit populations, bringing in kind of traditional protocols too, different approaches and different ways of seeing research and knowledge. So, Western knowledge, but also Indigenous knowledge and the value of both. Different protocols with elders and knowledge keepers and kind of bringing them on too. And I think, one of the learning experiences for us at least is, patient partners really kind of keep us in check as researchers. So, checking our assumptions and really kind of calling us in too. So maybe I'll pass it on to Carmen or Sandra for some of their thoughts. Thank you.
Thanks, Jia. That's great. Yeah, let's pass it on to Sandra, if that's all right. Can I put you on the spot?
No problem.
Maybe,
So
maybe it's a slightly different question, actually. Maybe it's why did you get involved with research, and what are some of the lessons and advice?
Yeah, because it's hard not to respond to those, but I'll go back and how I got involved. I'd just like to acknowledge Dimitri, though, because he did indicate an important thing. It's not something that researchers are trained on. So he was willing to listen to the patient partners and learn from us. And we have a great rapport. So, but my start in research actually goes back when the Liver Foundation asked me to share my lived experience at an event, and that event turned out to be the original meeting of what transformed into Can Restore. And Can Restore is done by two major researchers, Sunita and Tanya, that Dimitri led into. And so how it started is when I was there, and I obviously got to attend the whole meeting, which was good, not just, be there to share my meeting. I got to listen to a lot of things, and then I made my notes and decided what I was going to talk about. And it was at that meeting that I realized how much knowledge that I had in my lived experience that would help in research. And then I made a list of all the things that I thought that they should consider. But once I got going in the process, because obviously it took a lot of years to get to now where we have this amazing website, and now we have the physical exercise hub, and then all the work that all the different researchers are doing. It was understanding the need for research. So if you take, for example, the research that they were starting, they wanted to show the importance of exercise pre and post transplant. So as a transplant recipient who didn't get that, I'm like, yes, we need that. Let's do it. Let's get everyone to be able to do what the lung program's doing. We'll get all the doctors on board and we'll implement it. Well, no, it's like, hold on, Sandra, back up. First of all, we have to go see all the papers that are out there, which is called the white paper review. Then we have to show the importance of how that works. And so we did all that, and we had our data, but then it's the knowledge translation part. And this is the part as a patient that I do have a hard time with, because I don't have a problem getting it out because of the amount of networks, connections I have, and others within the community that can also share it. But it's actually, we don't necessarily always get access to the reports. And also, it's how do we actually then take that research and put it into practice, which can take time. So that's how I got started, and just one project after another, and it's going really great. And what can I teach for you? Well, I just said, it takes time, patience, and understanding is required, which patients don't have. We want things now. We want our new livers or new kidneys now, and we want everything to be good.
Of course. Carmen, do you want to chime in on this one before I move on to other questions?
Good morning, everybody.
Good morning.
My involvement with research from the family support role is multifaceted. First of all, speaking as a Indigenous person, we are a relational people, so it's all about relationships. And my daughter was transplanted almost 23 years ago this fall at Sick Kids. And we developed a really good as a family relationship with SamanthaAnthony. And that has continued through over the years, and we've participated in a few of her research projects. So first of all, because Dr. Anthony is such a lovely human and really, I think, puts the family and the patient first in what she does, that's what drew me in and to feeling safe. And then I guess on the other level, it would be I have a vested interest in research because it will hopefully inevitably help to prolong my daughter's life and to make her life better. So just a simple answer for you. And then a third prong that would go into that would be I'm politically involved with my nation. And so out here in British Columbia, the Métis Nation British Columbia, along with the Ministry of Health, with the BC Ministry of Health, did a research project that was published in 2021 now, I believe, with Métis Nation British Columbia. And our women and girls, in terms of all of the social determinants of health, have come out at the lowest level. So I have a vested interest in how healthcare affects our women and girls in particular. Obviously, my daughter falls into that category. So I'm always willing to share the patient family perspective, and not only what I say is it necessary, but it should be probably in some respects at the forefront of how research is conducted. And perhaps researchers should always ask patients and families what they need moving forward. Thanks so much.
So true. And I think you're it sounds like what you're doing is going to, has the potential to really have an impact. So hopefully that, alrighty. Okay, so if I can, I'm going to go back to Dr. Rosenberg. So can you discuss any of the logistical or systemic barriers that you've encountered in integrating, PFD partners into projects, and how you've dealt with that, or how you've handled those challenges?
Yeah, no, it's a good question. And actually reflecting over the last 4 to 5 years, it's a learning process. So as we've heard from the other speakers on the panel today, I think it's all about relationships and establishing relationships, and even trying to meet on a one-to-one or smaller group session. And sometimes it can be challenging due to time commitments, but having regular meetings with the patient partners and the team, and finding out exactly what the patient partner wants to get out of it as well. I mean, there's always the introductory meetings, but then subsequently as the project evolves, it can be a few years time, or those expectations could change. And so I think that's probably one of the more critical aspects of making sure that you have engagement from the patient partners, but also they're benefiting from that relationship as well, and that their expectations haven't changed as the project evolves. The second aspect is, I guess, going back to the diversity of the patient partners and making sure that the project that you're capturing at least has the minimum amount of diversity. And that's been challenging at times, because across the transplant program, you've got multi-systemic programs, and sometimes the research, we study renal, kidney, liver, heart, lung. You can't always capture every single patient partner within that organ. We know that the trajectory, both in the pre and the post-transplant periods, are very different. Even across lung transplant, for instance, a patient with cystic fibrosis who went through transplant 10 years ago would be very different today, and the expectations and what a lung transplant patient faces today, for instance, just the newer therapies. And different disease states as well. I do have to give a lot of credit to CDRP, who've helped facilitate the patient partners. I know for some of the other projects that are outside of transplant, it's been a bit more challenging to identify patient partners. Certainly we can do that from the clinical sphere, but there's always the patient barriers approaching individuals or patients to participate in research, there is a conflict of interest, whereas CDRP helps facilitate that process to some degree as well. And then I guess finally, the expectations from the team as well. So working with the patient partners, but also the other co-investigators on the team, how do we engage the co-investigators to work with the patient partners? And that's probably been a bit more challenging, and that's something I'm learning as well, because I think there's both benefits to making sure that there's a lot of cross dialogue between the other investigators and the patient partners on the team, and it's not just the patient partners with the co-principal investigators are the ones that are driving the project. So those are just some considerations I can always add, but I'd like to go to the other panel members.
Sure. Yeah, you try to avoid those silos, right? You try and reach out to other teams. Absolutely.
Exactly.
All right. Anyone else want to comment? I can put Jia on the spot again because you're a researcher, perhaps.
Yeah, I definitely do want to echo everything that Dr. Rosenberg has shared. I think time commitment and meeting patient and family partners where they're at. Our project is BC all the way to Ontario, so different time zones, and patients and families also have their lives, their different responsibilities, their roles, and especially self-management or caregiving needs too. So trying to work around that and be as flexible and offering as many opportunities to keep partners engaged and support is really important. I think also proper reimbursement for their time is also really, really important, acknowledging the time commitment, their experience, and their expertise. And I think that's, we've been trying to follow the SPOR guidelines for honorariums to recognize the time commitment that patients and families put in. I think that's something also that CDTRP does a really good job in, with providing funding to support patient partners and that capacity building. Yeah, I'll leave it to the other panelists too if they wanted to share their thoughts.
Sandra, Carmen, either of you want to add to that at all, or I can move on if not?
Well, sure. I'll have to answer the question that we have for ours as an individual about recruiting, like as patient partners, recruiting people. So taking off what Demetra and Jai said, it's like, I think it's like getting to understand the value of patient engagement. And so one of the things I think is important when we're setting, I just helped in some documents I have for Patient Advisors Network, and it was about, those are like safety and ethics about people getting involved. And one of the things is like setting up a meeting just to meet and get to know each other. And you'll hear patient partners say, I'm more than just my organ and my knowledge about my health experience, right? Finding out what other skills they have and things like that. But I also find, like, again, with Patient Advisors Network, there was a survey that we did, patient partners across Canada. It was like 658 people that filled this out. And it came back that the majority of people that get involved in research are white, educated women who are retired. So that's because not only, like, it's not because others don't want to get involved, we just haven't set up the environment for them. For example, we're running most of the meetings during the day, and most researchers I do. We're not looking at the facts that some of the people we're trying to reach don't have the equipment, don't have the internet, and really, in proper engagement, we should try to come to the communities, and that's more of like a bigger type of community on the spectrum. But I'm finding that becomes comes hard as well. And I'll just answer another question too about, and I'll go on. I'll pass it on to Carmen to finish her thoughts on it, please.
Thank you. I'll speak from the perspective of Indigenous folks, and again, I don't claim to speak for everybody, because Indigenous peoples across Turtle Island are very diverse. But what I would say is the challenge for researchers is to conduct themselves in a way that is often outside of the traditional norms of research, right? So I mentioned before relationship building, and if those of you who are on here have done your homework about Indigenous folks on Turtle Island, there's been a lot of harm that have been done to Indigenous people, and particular emphasis on racism within the system. So it's really incumbent on researchers to think about how they approach Indigenous peoples, and to try to just trying to choose my words. I'll just circle back. I think it's important that within the research, and I understand that there's certain perimeters that researchers have to function within, but there needs to be time and space to build that relationship with Indigenous people. And sometimes that's the focus of the research, is just to build relationship, to be in community, and to not ask questions and to not ask anything, but to just build a relationship of trust, excuse me, before you can move forward. So I would just say that there are unique challenges, and I would say it's probably the same for different ethnicities, right? Get to know your audience, understand the cultural nuances, the norms, learn about the protocols, and be patient, and learn how to relationship build before you get into the nitty-gritty of what you're researching. Thanks.
Thanks, Carmen. So we're down to the last few minutes. We're kind of pushing our time, but a little bit, but at the same time, it's an interesting conversation. So, one last question, and if I can, maybe I'll just go, like, if we could do 30 seconds for everybody. So what advice would you give other researchers or trainees, regarding patient engagement and support and approaches for a patient engagement? Any thoughts, Dr. Rosenberg?
Yeah, no, certainly. I mean, 30 seconds. I think reading about patient engagement, there's a lot of resources out there, and we're happy to share both at the institutional level and through CDRP. And Manuel has been excellent as well with the PDF family partners. And then also listening to some of the patient partners. They've been through this a lot more often than at an earlier career stage. They could certainly teach what works, and that it builds on that relationship. If you feel comfortable asking the patient partner, what do you think? How do we improve things? I think that's probably the more important aspect as well to consider. Thanks.
Thanks, Dr. Rosenberg. Jia, can I put you on the spot now?
Yeah, absolutely. I think, acknowledging, and I'm still a very new researcher, and I'm continuously learning from my patient partners and families. So I think that, engagement starting at the beginning. So involving these partners from the beginning in the grant writing stage, in the stage where you're trying to think about, design and methodologies, even what questions to ask, I think is really important. Patience is really important, and meeting your patient partners where they're at, and trying to have as many opportunities to engage. And I think, lastly, if you don't know, just ask, don't assume, ask your patient partners what is appropriate, ask them how they would like to be involved too. Don't kind of set kind of concrete roles for them, but ask them what they want and how they want to be engaged. Yeah.
Perfect. Thanks, Jia. All right, Sandra, 30 seconds for your thoughts.
Well, 30 seconds to what Jai said about when you're asking your questions. I think it's important to look at the list of patient priorities we have from our original meeting in 2015, compare that to what researchers are, and let's come to something that is a balance. I also think you need to understand patient engagement. So for example, as Dimitri said at the beginning, it's not something you're trained in, but we need to learn about research. So I think it's important that there is some kind of education or curriculum where people in research that are dealing or having patient partners involved, and hopefully in the future that's everyone, that they take some kind of course, and there's lots out there. And then understanding, again, like when I talk about patient partner engagement, is understanding what exactly does co-design mean. So for example, like, sometimes you'll see like the main researcher come in with the patient partners, but at other times you need to bring the whole team in as well, so that everyone's learning in that, because I still am a firm believer that until you see it working, you won't know. And the other thing is just to keep in mind that, the trauma and the triggers that can happen, and, just make sure that you have empathy and things like that. And we talked yesterday about timing, don't just give like a couple minutes for someone to share their story, and acknowledge it. Thank you for sharing your story and things like that. So, but in this group here and other groups, I think it's working well. So we just need to, again, learn from each other.
Absolutely. Thanks, Sandra. And Carmen, I'll give you the last word.
Sandra said it perfectly. I don't really have much to add. She raised many good points there. I would just like to personally thank Dr. Anthony for her research and for her patient-centered care in what she does, and to thank her for helping my family get through a really challenging time in our lives. And thank you to all of you who are doing the research. No pressure, but I'm putting it all on you to make life better for my daughter moving forward so she can get another 23 plus years. So thank you all for the work you do.
Nice, awesome. Okay, I think we're a little bit late on time, but we'll wrap it up there. And I just want to make a real quick comment. Jia mentioned Mary Bocage. She's she passed away recently. She's close to our hearts, and so just some warm thoughts and memories of her. But so today, thank you all for this is a really informative session. So we'll close the morning session. Please join us back at 1:30 Eastern Time for our session, followed by a workshop exploring CDTRP member priorities in equity, diversity, and inclusion.